Good evening, everyone. Thank you for joining us tonight for yet another Chris O'Brien Lifehouse CPD series and tonight's presentation on endometriosis. My name is Lydia Koenig. I'm CPD Program Officer at Central and Eastern Sydney PHN. Also working with us tonight, Lauren Thomas, my colleague, Antenatal Shared Care and CPD Program Officer. As always, I'd like to acknowledge traditional custodians and sovereign people of the land across which we work and meet tonight. I recognize the continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. And I would like to introduce our facilitator for tonight, Dr. Claire Stewart, our local GP and also editor for the Health Pathways.
Thanks, Lydia. To say welcome to everyone as well. I'm just going to first give you a really quick update about Health Pathways Sydney. So hopefully everybody knows about Health Pathways, knows that it exists, knows what it does. There are two Health Pathway sites for this area. So there's a Sydney Health Pathways site and also a Southeastern Sydney Health Pathways site. You choose which one to use based on where you will be referring your patient. So Sydney includes RPA, Concord, Canterbury, Balmain hospitals, and Southeastern Sydney, Prince of Wales, St Vincent's Sutherland, I think. The login details are actually the same for both sites. So the username is connected and the password is healthcare for both of the sites. If you have any problems, you can always email any problems logging in or anything like that, and we'd be happy to help you. If you go to the next slide, Lydia. So just a really quick outline of how it works. On your left there, you'll see the homepage. You can type in and search at the top. We have pathways that are both clinical and referral pathways. So you can look for clinical things like endometriosis, or you can look for how to refer to the gynecology clinic. So we have pathways that do both of those things. You can also search for sort of investigation type services. And there's an example of that on the screen there. When you go into the pathway itself, you'll see down the right-hand side of the screen, there's a little menu that will open up all the drop boxes for you. So you can open them all up in one go. You don't have to open them up one at a time as you go through. And you can search on the pages themselves as well by just doing a Control F search, which is also helpful sometimes. If you go to the next one. Yep, so again, use Southeastern Sydney or Sydney based on where you're sending your patient. This is a list of some of the Sydney health pathways that already exist for some of our gynecology topics. And then in the next slide is some of the Southeastern Sydney pathways that exist. If you are accessing the pathways and you find that you've got a comment or you want to give us some feedback, there is a feedback button at the bottom of each pathway. That sends an email to our project officer and we read all of those emails. So if you have feedback, please let us know. If it's to do with, you think that a drug dose is wrong or the referral is different, that is all things that we look at as soon as you send that feedback in. So that's really helpful for us as well, because we can't know everything all the time, I guess. Yeah, so hopefully you're all using Health Pathways. If you're not, or you have questions, then you can always send an email and we'll be happy to help you get started. Thanks.
Thank you, Claire. And now we're going to move on to our presentation. And Claire, over to you.
Yeah, perfect. So I'm just going to do a quick introduction for our speaker tonight, who's Clinical Associate Professor Michael Cooper, OAM. So he's a gynecologist in private practice in Sydney, affiliated with Sydney University, graduated from Sydney University in 1984 and received his fellowship qualification in 1995. Spent extensive time training in endoscopic surgery in Europe, the United Kingdom and America. He initiated one of the early endoscopic training centres for gynecologists in Australia and is regularly involved in workshops to train other doctors and students. He was previously a board member of the Australian Gynecological Endoscopy Society and a member of the Scientific Committee of the International Society for Gynecological Endoscopy. He has been an advisor to the World Health Organization on research and training in gynecological endoscopic surgery. And he received an Order of Australia Medal in 2018 for services to gynecology. So Associate Professor Cooper has been the author of over 50 articles and book chapters published both in Australia and internationally, and has spoken widely within Australia and overseas. He has been an invited surgeon to many hospitals in Australia and Asia. His major interest is in the treatment of endometriosis, particularly requiring advanced surgical, robotic, and/or assisted conception techniques, including IVF. He's performed over 2,000 operative laparoscopies for the treatment of endometriosis. So I think overall a very well-qualified person to speak to us tonight about endometriosis. So over to you.
Thanks very much, Claire and Lydia, for the invitation, and it's a pleasure to sort of meet you all. It's a little bit weird in this sort of day and age to be running these meetings this way, but I do understand how it's very convenient for people as well. Maybe I'll just start sharing my screen. And by way of sort of introduction, just to flesh out a little bit what Claire has just indicated, I'll just sort of tell you a short journey as to how I got where I am. So I grew up in Western New South Wales on a property, and sort of thought I would be a sort of a traditional GP really, and you know, would deliver a few babies, take out some appendixes, put some stitches in people. And then when I finished medicine, I realised I really didn't like sick people that much, and that led me to obstetrics and gynecology. And midway through that, I realised that sort of, you know, for a lot of women, you know, men delivering was probably not optimal. And around about that time, there was the introduction of these small chip cameras, which revolutionised surgery. So instead of doing laparotomies, we could convert to sort of laparoscopy. And that started me down a sort of a world where I was very early on involved in that. And then as that moved on, we started doing a whole lot of prolapse surgery. And when the meshes sort of took off, I thought to myself, this was sort of weird, and I really didn't understand why people were using meshes, and I was concerned about infections and things. And so I really completely changed my practice, and that really ended up me focusing on endometriosis. And so that's the way I've got to this point. Page down. All right, here we are. So what I'll do tonight is I want to give you, I guess, perhaps another feel as to my feeling on endometriosis, and hopefully give you all some things that you can use in your own practice in the management of people with this most difficult and really poorly understood sort of condition. So I'll talk about the definition. I'll run some issues about sort of the associated abnormalities. I will talk about surgery, but really to try and give you a bit of a feel as to the things that we experience and that we're concerned with. I'll talk about some fertility issues, pain control, and then also some concepts about inflammation. And ultimately what I'd like to do is sort of give you my sort of 4 pillars of management, the way I try and talk to patients and give them some ways that they can deal with this, you know, on their own terms. Understanding that, you know, if you can take sort of ownership of at least part of the problem, it really becomes a great big attribute for people with sort of the chronic conditions such as this. Below, we've listed some of the people that we think are reasonably high profile and have probably had endometriosis. And as you all know, it's exceedingly common. It's at least sort of 10% of the female population, and possibly higher in sort of more recent reports. So if we just start talking about the current sort of definition, as it were, so the current sort of view is that this condition is the presence of endometrial glands and stroma outside the uterus. But the difficulty is that there's no comment about the multiple other abnormalities that these patients have. Hence, we don't tend to talk about these things. We have no routine tests to scan, image, isolate these or identify these problems. And that really sets up a problem, because that means our expectation management becomes a problem. So if you believe the current narrative and the current definition that it's simply some glands and stroma outside the uterus, and you tell that to your patients, then they will understandably think, well, okay, why can't you just remove that and that'll be the end of the problem? But the difficulty is that that's not the issue. And so we have this sort of, we've defined ourselves into a situation that we're set up to fail. And what that means is that both the patient's expectations and the people who are caring for these people have significant problems in terms of giving them, clear guidance and a capacity to deal with the problem. By way of illustrating this, this is a recent article from The Lancet, essentially identifying the fact that what we're talking about is really a chronic systemic inflammatory problem, and that as part of that problem, these patients have this ectopic endometrial glands and stroma sort of outside the uterus. So there's multiple issues. If I move just slightly sideways and start talking about the symptoms, you'll all appreciate that sort of a large number of these people will have pain, but not necessarily all of them. Of the subgroup of people who are trying to get pregnant and having difficulties, and there's no obvious reason why, some 50% of those people are going to have endometriosis. It's very common for them to have lots of symptoms, so bowel, bladder, sexual pain, leg issues, backache. Irritable bowel sort of problems, or having a diagnosis of that is also exceedingly common. And then we get sort of systemic issues, so fatigue problems, headache, other systemic issues, and then immune inflammatory sort of conditions. I'd want to point out at least one thing, and that is that when you're talking to patients, if they describe premenstrual spotting and menstrual irregularities, so sort of classically a brownish discharge just before starting a menstrual period, that's a very strong sign. It's probably more than 70% of those people will have endometriosis. And when you're screening for people, it's a great question to give you a feel as to what you might be dealing with. Because as I say, if they comment on that, it's highly likely that's what the problem is. From an imaging point of view, if you're all aware of ultrasound, but I'd sort of make the point that if you do come across a patient who has an ovarian endometrioma, that's a really big deal, because that means that they have almost certainly much more extensive disease. Some of those people will have the bowel involved, so within the cul-de-sac, and they'll have a situation not uncommonly like this patient in the bottom image here. So here we've got a uterus, two sort of kissing ovaries, and you can see the rectosigmoid coming down, and it's clearly stuck to the back of the uterus, so that you can't see the cul-de-sac, can't see the top of the cervix or the vagina. So these people they're a special subgroup of people, and if you come across them, I'd warn you to take particular care, because there's particular problems for these people, which I'll allude to as we go through. More recently, there has been a significant, move towards using ultrasound and a specific technique for the diagnosis of deep invasive endometriosis. And the units around the city are getting better and better and better at picking this up. And it's a fabulous technique. It's not available everywhere, and it really depends on the operator. So it's a technique issue, not a technology issue. And I'd commend that if you're concerned that somebody might have endometriosis, particularly if you're over about sort of 25. In the younger age group, you're unlikely to get a pickup, but from about sort of 25 onwards, it's not uncommon to find something. In the absence of having access to ultrasound, MRI is also exceedingly useful, but that can be a bit more expensive. I point out that it's also difficult to understand the disease unless you really understand excision and what sort of happens. So here, by way of illustration, you can see on the left the bowel stuck to the back of the sort of the cervix, but it's a little bit like this. It's a fibrotic sort of situation, so that the tissue gets really pulled in, and when you release that sort of area that's abnormal, you can end up with a very large sort of defect, usually within the pelvis. And so there's this sort of iceberg concept, and I think a lot of people who have difficulties with endometriosis may have had a portion of the iceberg removed, but not necessarily all of it, and that leads to problems with ongoing symptoms, issues, and potentially more surgery. As I alluded to initially, there's multiple abnormalities with this disease. So we know in the top sort of right here, In this middle section here, this is a normal sort of view. So that ball of muscle is the uterus. This cylinder here is the cervix. Top of the vagina here, tube and a white ovary, and the uterosacral ligament, one there, one there. And there's a space here, which is the cul-de-sac or the pouch of Douglas. So the most common place to get endometriosis in the uterosacral regions. Here's an image of somebody on the right who has endometriosis in both of these uterosacral areas. And as I alluded to, so that the current definition is these endometrial glands and stroma outside the uterus. But we know, as I pointed out, there's multiple other abnormalities. This is a paper from our group at Sydney University quite some years ago, where we demonstrated that the eutopic endometrium of people with endometriosis is also abnormal. It's a difficult pathological test to do. Outside a research institute, we thought you may be able to utilise sort of an endometrial biopsy to diagnose endometriosis. And we went down that way for a while, but it turns out it's a very difficult test to do. But nevertheless, it does remain that the utopic endometrium is abnormal, and that creates issues, possibly in relation to the premenstrual spotting, or pregnancy issues, and also to implantation, particularly IVF. But I'll allude to that as we go further. You'd all be aware that there's multiple genetic abnormalities. We haven't been able to isolate any particular one, and it's quite complex, and there's a lot in it, but there's no question there's a genetic component, so it does run in families. We know there's a whole pile of immune anomalies. So if you look at the peritoneal fluid of patients with endometriosis, there's significant toxins there, and there's lots of sort of problems at that point. We're pretty sure that the eggs of these people are different, so that you can look at implantation rates in non-endometriotic women receiving donor eggs from affected individuals, and you get decreased sort of pregnancy rates. There's a whole pile of evidence emerging suggesting that there's environmental influences. So the field of epigenetics is an issue here. We're pretty sure that endocrine disruptors such as the BPAs are involved, and then there's a large number of other things. The difficulty with this, of course, is that the BPAs now, despite sort of, avoiding water bottles that don't have BPA in them in the plastics, it's pretty much through the water supply. So all of us and our patients, when they're having showers, they're sort of they're drowning in the stuff, which is a significant problem. There's a strange thing in relation to body mass, which may have something to do with the metabolic profile of these patients. And it's notable that they are all sort of reasonably thin individuals. So whilst at times you may see someone who's overweight, the vast majority of them are in the sort of the normal to low body mass index, and there's a sort of inverse proportion in relation to the presence of endometriosis. I alluded to inflammation. So endometriosis, we're pretty sure, affects the metabolism in the liver and adipose tissue, ultimately resulting in systemic inflammation and alterations in brain with increased pain, perception, anxiety, and sort of mood disorders. And it's been interesting to me that my regular anaesthetists, just talking to these patients, can have a feel or a sense as to whether they've got endometriosis or not. And there's something possibly about the phenotype of these people that you can pick up. I alluded to irritable bowel syndrome before, so here's some work from our unit, again suggesting that large numbers of people with endometriosis have been diagnosed with irritable bowel syndrome. And as you would all appreciate, irritable bowel syndrome is a diagnosis sort of exclusion, or in other words, you've done a whole pile of tests, but you can't find anything. But none of those tests involve examining the outside of the bowel or the abdominal cavity. And clearly there must be some swap over between these two entities. It's not as though all people with irritable bowel will have endometriosis, but a significant number of them will have that as a diagnosis. And the endometriosis is actually probably the underlying diagnosis. We know there's a number of chronic disease associations. So with cancer, the cancer issue is mostly related to the ovary, and the linkage is not particularly well known, but it's certainly present. It's more common in the people who have endometriomas or endometriosis or chocolate cysts involving the ovaries, particularly if they're larger sort of sizes. So if they're bigger than about 8 centimetres. I, post-operating on people, tend to continue to scan people on a yearly or second yearly sort of basis, looking for recurrence and also then looking for tumours and things. And over the years, I've seen a reasonable number of perimenopausal people who have turned up with, unfortunately, ovarian sort of tumours. Interestingly, breast also, perhaps related. And for some strange reason, there appears to be an association with melanoma. As I've alluded to, there's a lot of people who have autoimmune issues, and it's very, very common for people to have things, for example, such as thyroid issues, asthma, atopy, cardiovascular, neurological issues, and, as I alluded to, inflammatory problems. This is not a benign condition either in relation to endometriosis or in relation to pregnancy. And we know, just looking at large numbers of patients, so here's analysing over 14,500 British cases, there's increased risks of all these issues on the side. So miscarriage, ectopic, hemorrhage, prematurity, growth retardation, hypertensive disorders, and placental problems. There's an interesting theory from Iva Brozens from Belgium, in that it may be, nobody knows, but then there's multiple sort of theories in relation to endometriosis, but it may be that it's protective for pregnancy when you're young, so that humans require deep placentation. If you get pregnant within your first 1, 2, 3, 4, 6 menstrual cycles, you haven't developed sort of deep placentation, and those pregnancies are often significantly, have significant problems. So many years ago, we used to run an early pregnancy unit for young women at King George, and they had very high rates of hypertensive disorders, growth retardation. And there's a theory, at least, that endometriosis, by impacting on the eutopic endometrium, as I alluded to before, may enable a more successful placentation and therefore decrease the risk of preeclampsia, hypertensive disorders and the like. It's just a theory, it's intriguing, but it's potentially possible that what we're looking at is a condition, and the reason we don't understand this condition is because it may be that this is a condition that at one point of life is an advantage, an evolutionary advantage, but with the passage of time and the way we live our modern world, as people put off getting pregnant and as they get older and have fewer numbers of children, it then becomes more of a problem. An intriguing thought. What can you do in your sort of world? I'll run through some things that I think are sort of useful. I'll leave medications for a minute, other than to say that the long-acting agents can be great. The four sort of, we find that, you know, this is we're talking about an inflammatory problem deep within the pelvis. So a lot of these people have quite significant sort of tensing of their pelvic floor. They get, excuse me, associated issues progressing to the back, legs, abdomen, visceral issues. So physiotherapists are really, really useful if you can find somebody who is skilled in this area. And they're sort of difficult people to find, but they exist and they're out there. And if you do have a lot of patients, I'd strongly encourage you to try and develop a relationship with them. I'll talk about pain in a little while, but from an inflammatory point of view, mindfulness, exercise, diets, decreasing inflammation, different sorts of supplements, which I'll talk about, so turmeric and acetylcysteine in a minute, are all useful things to add into the equation, and they're things that the patients can do and take part of their own care themselves. And I think it's a really, really valuable thing to get them involved. Not so long ago, I read this book by Peter Bruckner, who some of you may know about. He was a sports physician. He was the doctor for the Australian cricket team and did a whole pile of work. ultimately looking at this sort of anti-inflammatory type diet. He looked at the sort of the nutritional pyramid that you would all know about, and largely considered that that pyramid had been put together by sort of the big sugar industry, and wasn't necessarily the way things should go. So I'm suggesting that a lot of my patients use a sort of a diet like this. And I sort of emphasize on the right to try and avoid these vegetable oils. And I'll allude to why that is in a minute, but they're sort of seed oils and they appear to be significantly problematic. There's another chap, David Gillespie, who interestingly is not a doctor, he's a lawyer, but he's written this book and he's researched it. It's really sort of fascinating. Again, I'd commend you to have a look at it. So these seed oils that are high in omega-6 oils produce a number of things which are significantly toxic. So MDA and 4-HNE, which interact with DNA, they increase cancer risk, they're neurotoxic, they result in Alzheimer's, motor neuron disease, multiple sclerosis, macular degeneration. So if you change your diet, if you've got macular degeneration, you can reverse it. Rheumatoid arthritis, allergies. They appear to have issues with sperm count and the quality of sperm, and I'll move on to that in a second. But that has the potential to impact on offspring. And there's some suggestions that it's involved with endometriosis, and that people with endometriosis have higher rates of 4-HNE within their peritoneal fluid than the general population. Just to move sideways just for a minute, in the world of fertility, you'd all be familiar with the fact that the egg will bring the sort of broadly the chromosomal makeup and the building blocks to create an embryo. And we all thought that the sperm simply brought some male chromosomes to the table, but it's becoming increasingly clear that the 90-day development of the sperm will bring the current environment to that pregnancy. So as we know, if your patient's a smoker or a heavy drinker or using alcohol or has a whole pile of other problems, those problems can be imprinted epigenetically into the sperm, into the genome, and hence impact embryo development. So for people who are trying to get pregnant, it's really important that the partner tries to lead as healthy a life as possible in the 90 days sort of prior to utilising that sperm, as it were. I alluded to 4-HNE just a minute ago. So it appears that patients with endometriosis appear to have elevated levels of this 4-HNE in their peritoneal fluid. So is this a metabolic thing? Is it a diet thing? Don't know, but it would make sense to me that you should try and look at various diets to try and assist this. I alluded to N-acetylcysteine before, and there's papers to tell us that, look, it does impact in terms of pain. It appears even to decrease the size of endometriomas and assist with fertility. So it's again, it's a sort of an easy thing to suggest to patients, and it's part of the things that they can look after themselves in their sort of journey of managing this. We use 600 milligrams 3 times a day for 3 consecutive days a week for 3 months. And that seems to be the sort of the way that people run things. Moving on to medication, it's worth pointing out that something like a third of patients really don't respond very well to the contraceptive pill, possibly because they've got some sort of resistance to progesterone. Clearly, you want to use, maybe if I go back a little, I'll move forward with this, but it's reasonably well appreciated that if you get pregnant, then that appears to assist endometriosis symptoms, possibly staging, progression, etc., etc. Absent pregnancy, you can mimic have a pseudo-pregnancy by using contraceptive agents such as the progestogens, MPA, northistrone, and the like. And in mimicking pregnancy, that will decrease your symptoms. Not for everybody, but it's certainly, as a first line, it's worth doing. We use a lot of Mirena, and there's reasonably good long-term data to tell us that will impact decreasing the requirement for more surgery, symptoms, and potentially maintaining fertility. And for problematical people, I tend to use symbiotically Mirena plus Implanon. So if you're seeing a patient and if Mirena is not working very well, it may be reasonable to add in something, add another agent such as Implanon, or alternatively something like Visane. I sort of tell patients it's not dissimilar to a cancer treatment in the sense that we might use chemotherapy, radiotherapy, and surgery, and the chemotherapy will be different agents, all acting sort of symbiotically, and it's a sort of a similar deal with endometriosis. More recently, we've started to look at GnRH therapy with ADVAC. GnRH therapy on its own, I haven't found particularly useful other than for particularly individual circumstances. And the reason is everybody hates it, lots of side effects, and it's a little bit like morphine therapy in the sense that, you know, once you stop, you're back to where you started again. More recently, there's some oral agents being potentially looked at, and that they may have a place, but at this point in time, I don't have a lot of experience with that. I'll just spend a few minutes talking about pain. So it appears that these patients become sort of hypersensitive to pain, and they get central pain sensitization, and there's some sort of association between their pain, endometriosis, and brain remodeling. And increasingly, I'm starting to think that what we might be finding, not dissimilar to sort of lots of different chronic pain situations, is there's an inappropriate signaling problem, in the sense that you have a stimulus. Acute pain is basically a communication mechanism to say, okay, your foot's in the fire, take it out of the fire. But in a chronic setting, we know that you can have, for example, amputations, and you can have foot pain, leg pain, even though you don't have a leg. And it may be that for some of these people with chronic sensation issues, the stimulus that they receive is inappropriate for the signal that's sent. So they perceive severe pain when in fact it's not that, when in fact the stimulus is not that great. I'd commend you to have a look at these. There's a video, Tame the Beast, and that's this guy Mosley, and he tells a story. He's an anaesthetist who tells a story of walking in a forest, felt this scratch on the side of his leg, followed by this intense pain, looked down, and he'd been bitten by a snake. Took some considerable time to get over that, lots of pain, lots of issues. Years later, walking in a similar place, felt a scratch on the leg, followed by this severe pain, looked down, and he just basically scratched a leaf, but it set off this sort of pain mechanism. This other book, Why Does It Still Hurt, is also very useful, and I suggest to a lot of people that they look at this. It's a recent sort of thing, and it's highly up to date, and I think it's very relevant to the sort of the problems we have with chronic pain and the difficult patients that we're all having to deal with. As an illustration of the pain and the sensory issues, there are companies such as this, Endosure. I'm not quite sure how correct this is, but nevertheless, they describe and say that they can do a non-invasive, highly accurate test for endometriosis. And what they do is they put these 3 electrodes on a patient's abdomen, get the patient to drink some water, and then 30 minutes later, they run this sort of algorithm and claim that they can get an AI-derived result to tell if people have endometriosis or not. I'm not sure if this is correct or not, but nevertheless, the fact that they can, even if it's half right, it suggests that what we're dealing with is a sort of like a sensitization thing. And I think that sort of fits with everything else I've just been saying. I'll talk a bit about surgery and give you a feel about some of our world. And you're probably aware of certainly some of these sort of things, but it's difficult. There's clear evidence of both occult and microscopic disease. So we know that you can have patients, you can do a laparoscopy, which is the gold standard for looking at endometriosis, and you can find, what looks to be completely normal. But if you take a biopsy, some of those patients will have endometriosis. There's staging problems, so there's multiple staging systems, and my severe disease versus somebody else's severe disease can be significantly different. The patients can claim they've been told they've got sort of high-end disease when in fact it's not that bad. And the staging systems really don't help in terms of prognostication and being able to tell people what to do. So that's a big issue. There's a very, very substantial surgical bias, and the skill of the surgeon is a significant issue in terms of results, statistics, and ultimately pregnancies and long-term results. This is a disorder that really crosses different surgical specialties, and at certain times you will need multiple skill sets and multiple teams, specialist teams, to deal with it. As I've indicated, it's not always easy to diagnose, and somewhat surprising, it's very easy to underdiagnose substantial disease. So I've seen over the years a number of people who've had laparoscopies, they've been told there's nothing going on, but in fact, if they haven't had the uterus manipulated in the appropriate manner, you can see substantial disease that's just been sort of missed. Just sort of illustrating, I guess, some of the inflammatory nature that we're talking about. On the top left here is normal, and you can see everything sort of smooth, isolated. Here on the right, sort of before operating and doing anything, you can see this inflammatory nature. So this poor individual's pelvis is, it's inflamed, it's toxic, it's bleeding, and it's not, it's highly, understandable that she's going to have, a lot of these people will have significant pain. Similarly, underneath here, here's somebody, you can't see the cul-de-sac, bowel, everything sort of stuck together. At the opposite end of the field, we see these issues. So here we have sort of subtle bowel disease. So you get these tiny areas on the sigmoid here, more here. Here's a more obvious one in sort of small bowel areas in the cecum, appendix. And the difficulty is, what do you do with these? You can't chop all these out. You can't take out large areas of bowel. So I find this really difficult, and it's surprisingly not uncommon to see this. And so, you can well understand that if you had an irritable focus on the surface of your bowel, it's quite conceivable that you'll have irritable type symptoms. More illustrations, the same sort of thing. Again, these small sort of areas. I'll spend a few minutes on this slide because this is a lot of what I see, and perhaps you're seeing in your own world as well. So again, just to go through, on the top right, we've got normal uterus here, cylinder of the cervix here. I've got a manipulator through the vagina and then into the uterus, and then I've angled the uterus 90 degrees forward. So the fulcrum point is just here, and this bulge here is a metal area in the top of the vagina. Here we have somebody who's got uterus here, bowel here, clearly stuck to the back of the uterus. You can't see the cervix, you can't see the top of the vagina, and the cul-de-sac's obliterated. We've operated, and this is the post-operative shot here, and we can see there's an incision line running all the way around here, sort of like a butterfly, so encompassing both sides of the pelvis underneath the ovaries, and then over the top of the rectum. Now you can see here's the cervix to this point here. You can see there's a 90-degree angle here, and that's the metal delineator in the top of the vagina. And you can see a clear tube here, which is the sort of the rectosigmoid. So we've removed basically the cul-de-sac and the endometriosis that was present in that area. What I see not uncommonly is this situation. So here's somebody, uterus, ovary, bowel stuck to the back of the uterus, can't see cervix, can't see top of the vagina. Somebody's operated and they've isolated both sides of the pelvis, so we can see a ureter there, another ureter there, and they've sort of taken off the sort of the serosal sort of peritoneal surface off the top of the rectum, but you still can't see the cervix, you still can't see the top of the vagina. So basically, the endometriosis is still in that rectovaginal septum. So unfortunately, all that's happened is that the next surgery is going to be more difficult than that one. Just a few comments about involvement of the cul-de-sac and when the bowel's involved. So these are the people that you're concerned about when they've got, say, an endometrioma, as I alluded to initially. It's my feeling that really around the world, these cases must be fairly similar, but what we see in different units is dramatic differences in terms of surgical technique. And I think really it depends on the experience of the gynecologist. So if the gynecologist is not that experienced and the team hasn't done a lot of this, they will get a colorectal surgeon involved early, and the colorectal surgeon will do the dissection. And the dissection they've been trained for is a sort of segmental resection for sort of carcinoma. So more patients will get segmental resections than either just a shave or a sort of a disc. And I think that's a big issue. So some units around the world will have very high rates of segmental resections, whereas other parts of the world, presumably it's the same sort of population, will have very low rates of segmental resection. And for the vast majority of people with endometriosis, they don't need a segmental resection. There's a significant morbidity attached to it, which is long-term. And for most of them, you can get away with a much more conservative sort of procedure. You can get it in the bladder. So here's a nodule in the bladder here. You can see a sort of a golf ball size thing that's not a catheter that's sitting sort of anterior to the rectum, sorry, anterior to the uterus. And cystoscopically, you can see these sort of lesions here. So for these sort of people, we would excise those areas. So this is significantly abnormal with everything fused together, the bladder fused, round ligaments pulled in, and a big area there. And we've just made a big incision. Here's the endometriosis. You can obviously see the Foley catheter, and then we've just repaired it. And these people do incredibly well. You know, the bladder heals exceedingly well. They need drains, catheter bags and things, leg bags for 10 days or so. But in general, they do very well. It's reasonably uncommon, but the ureters can be involved, and it's worth looking for. Most of the people who are doing deep invasive scans now will comment on the ureters, but it's a sort of a trap for those people with more severe disease. So on the right, to put this in perspective, this instrument's 5 millimeters, and here we've got about a 8-10 millimeter ureter, which is maybe 5 times bigger than normal. Most of these people don't need to be reimplanted. The area that's sort of strictured almost invariably is at the level of the uterine artery. And if you can excise that area, even if you need to sacrifice the uterine artery, you can release the obstruction and they don't need a reimplant. They might need a stent, but usually that's about it. You can get in lots of weird places. So we've had a case in the liver, so that is a bit of liver. You can get it in the diaphragm, so one here. This particular individual is right next to the IVC, which is sort of very significant surgical problem if you're going to deal with that. Here we've taken a bit of diaphragm out. The area we took it was so big we had to patch it, so that's a Gore-Tex patch in there. Here's, it's not that uncommon, but a cesarean section scar deposit. This one's pretty big. These have the consistency of basically of concrete. So, and some of the other areas within, you know, when we're dealing with this, it's just sort of rock solid. That area is so big, we had to take out an area of rectus sheath, and we've repaired that so that the patient doesn't get a hernia. A few words about adenomyosis. It's really a big problem, and we're starting to diagnose it earlier and earlier. I'm not sure if that's just the environment we're living in, or we're getting better and the technology is better with ultrasound, but it's a major problem. So if you find someone who has endometriosis and they have adenomyosis, that's really an issue. And you know, I do a reasonable amount of IVF, but in some, if they end up in the wrong sort of hands, their pain can be not managed particularly well, and it becomes a real issue. So talking to these people as to how they live their life, their you know, pregnancy sort of calendar, as it were, they need to have some really, I think, solid advice, because they can get into a problem with significant pain and difficulties getting pregnant. You all know there's a significant sort of stage effect. So the more severe your endometriosis is, the lower your fecundability will be. So this is one of my old bosses, Rob Jansen. back in '85, demonstrating in donor insemination cycles that if you had endometriosis, that was going to impact on your chance of conceiving. It's the IVF world is sort of swings from one way to another way, but and it sort of depends. I think the whole area here is significantly biased, and I think that's because increasingly there's been sort of a significant commercial focus to IVF, and what that means is that a lot of the people who are doing IVF don't do much surgery, and the converse applies as well. So individuals who do both will give sort of different advice, and that's reflected in the sort of the literature. Significant endometriosis does impact on success in IVF cycles. The more recent data sort of suggested it doesn't, but I think really that can be sort of debated. Again, moving back to the people with endometriomas, they're a special group, and there is the potential for damaging the underlying ovarian reserve in these people. So I always look at AMHs and just make sure the AMH is sort of reasonable, because there are individuals where their AMH is already knocked around, and under those circumstances, you might be better off to contemplate procedures such as simply draining the endometrioma, freezing eggs, and then going back and dealing with the situation definitively at a later date, and thus ensuring the potential for pregnancy down the line. We know that if you remove endometriosis, it's going to improve pregnancy rates in IVF. And more recently, there's more and more papers coming out showing if you remove deep invasive disease, same thing happens. And more recently, we would tend to do that with robotic surgery. The robots for the particularly the deep invasive disease are really fabulous. And I tell my patients it's the robots they sort of improve our dissection capacity. They improve our capacity to feel and remove the endometriosis. And I tell my patients a little bit like the difference between peeling a green banana versus peeling a ripe banana. The robots help us peel the green banana. So maybe sort of in closing, really we're talking about a very complex disease. There's a whole pile of definitional issues, and with that becomes an expectation management problem, which is a problem both for patients and for doctors. So unless you can flesh out what's actually happening, your patients are going to be dissatisfied. It is a better way to think of it is this is probably a chronic systemic inflammatory deal, and that this ectopic endometrium is only one component of that. There is distinct surgical issues with the appreciation of both the extent, the expertise, and at times patients will require skilled multi-specialty teams. From a pain perspective, I do think there's some sort of inappropriate signalling deal. And if patients can start to understand, read, educate themselves about this, that really significantly helps them. In relation to fertility, people who have endometriosis and get pregnant and don't have much done, they can still have issues post-pregnancy. And if they go down the wrong pathway, some of them can end up with multiple cycles of IVF while still having underlying endometriosis. Their pain gets worse, time goes on, they don't get pregnant, and they're very, very unhappy. Advanced disease significantly impacts spontaneous and IVF pregnancy rates. And I'd strongly suggest a sort of an individualized management program with excision plus pregnancy or pseudo-pregnancy with sort of contraceptives as the mainstay. But as I've added in before, I think there's sort of 4 pillars to this. So surgery, this pregnancy, pseudo-pregnancy sort of deal, pain mechanisms, so understanding, education, physiotherapy to assist with this, and then sort of anti-inflammatory measures that we talked about. Very happy to flesh things out if there's questions. If people want to put anything through to me, happy to answer that as well. I was asked to talk about the public situation at Prince Alfred. We do have a clinic there. It's look, I would like it to be a little bit more efficient than it is, but it's it sort of semi-works. We've got access to pain units and various other people. But a lot of the things I'm referring to, I think it's actually done better as an outpatient sort of situation. The hospital tends to get a bit clogged up. But anyway, happy to answer some questions, and thank you very much for the opportunity to speak.
Thank you so much, Professor Cooper. That was really, really interesting. And we do have quite a lot of questions, actually. So I might just get on with it, I think. So the first one is, as GPs, we see lots of women with, painful periods varying from mildly painful to very painful. And is there some point where you would think this is more likely to be endometriosis than not? Are all painful periods endometriosis?
Look, I tell my patients, broadly speaking, the people you're talking about, they're going to fall into basically mostly one or two groups. Either they've got, sort of what we sort of euphemistically call primary dysmenorrhea. So these are patients who there's no obvious abnormality. For whatever reason, the uterus, the myometrium goes into sort of, overkill with sort of spasm. So they get this sort of hyperspasm, early on, and then when they get pregnant, it relaxes and that's it. So there's those people, or if they don't have that, then they've got endometriosis. We don't have an explanation for either of those conditions, but broadly that's what it's going to be. I mean, obviously you need to image them because some of these people will have, malaria anomalies, other issues, but in the main, I think it's going to be one of those two things. And some people can cope with it better than others, and it really just depends on, where you're going with them. I mean, I think you can ask the question, as I said, if they've got premenstrual spotting, then they've probably got endometriosis. And those people, then I think it's perfectly reasonable to look at sort of contraceptive pills, progestogens, Visane, Mirena, Implanon, all that sort of stuff, adding in N-acetylcysteine, turmeric, physiotherapists, education about pain. And then sort of depending where you are at that stage, you look, okay, laparoscopy is the next sort of point. For the younger people in particular, and if I see people certainly with their mothers and things, I very much try and put off laparoscopy early. So even though there's this sort of feeling that there's a long time to diagnosis per se doesn't necessarily help you, in the sense that what we see a lot of is we can operate on someone who's, say, 18 or 17 or 19, and they often, not uncommonly, have a sort of a field change effect. So you look in, there's subtle changes, you biopsy, yes, it's endometriosis, but it's across the whole pelvis. And I sort of liken it to think that, when you're operating and you look at the peritoneum, you imagine it's a bit like skin, but it doesn't heal at all like skin. It's completely separate. And it's probably sort of somewhat mobile. So I would liken it to, for example, if you imagine an oil slick on the ocean, it can be incredibly sort of wide, but if you, with the passage of time as these people get older, that oil slick is a little bit like it's being pushed up against a sort of some sort of land body and gets sort of concentrated. And that's sort of what we see. So, it's really hard if you put someone through a laparoscopy and they've got this field change wide area effect, you're not necessarily going to change things by operating.
Mm-hmm. And then I guess going on from that, in terms of investigation imaging, as the first step, just, routine pelvic ultrasound. And then at what point would you say to someone, maybe you should consider having one of these, specialist endometriosis ultrasounds, or should we leave that for once we've referred to a gynecologist? Does it make a difference?
I think a lot of these people could be managed by GPs. The first thing to say is, like, just examining some of these people, you can actually feel, if you examine them, it's unlikely to find this under about 25, but the people who have the big time disease, you can feel something. They've got sort of nodularity at the in the posterior fornix. So you may be able to just examine them vaginally. Under 25, pickups with the deep invasive scans, as I say, is unusual, unless they have a endometrioma. If they have an endometrioma, then it's sort of reasonable.
Okay. So once there's a question here about laparoscopy once a woman gets to laparoscopy. So it says, so it sounds like it's better to have a laparoscopy by a gynecologist who does excision of endometriosis rather than ablation to ensure that everything is treated as completely as possible. Is that correct?
I think that's correct. Depends on where you are, of course. So if you're, say, up in the country or in a rural area, it may be appropriate to do a laparoscopy. I mean, some people do planning laparoscopies. Personally, I think that's sort of a bit of a waste of resources. It's expensive. There's extra risk. Increasingly, as I say, if you can get scans, you can work out, what's happening. And at times, I think most people will encompass or encounter situations where the endometriosis is much worse than they had realised or appreciated or planned for, or they didn't have equipment for, or the skill set, in which case you just sort of bail out. But broadly, I think it's better for everybody if the patients have one operation and that's the end of it.
Mm-hmm. And then I guess as a follow-on to that, there's a question here about women who are closer to menopause. And then do you recommend hysterectomy? Does that make a difference? Or would you do the same approach in terms of removal of endometriosis in the pelvis?
Yeah, my thinking sort of changed about this, but that particular subgroup of people, so of the people we operate on with big-time endometriosis, and then we don't see for sort of years, a large number of them, more than 50%, will have adenomyosis as an underlying issue. So it's really important to try and get a handle on that. It's a difficult diagnosis to make, but MRI, high quality ultrasound can tell you. So if those patients, if someone's in their 40s, 45 plus, significant pain, and they've got issues with adenomyosis or a suggestion that they've got adenomyosis, then a conservative procedure is really not going to help. Those people probably would be better off with hysterectomy.
Mm-hmm. And then is adenomyosis a variant of endometriosis, or is it a different condition?
We don't know, but it's probably a variant. So classically, it's sort of thought that the people I was talking about with the involvement of, say, the bladder, as I was sort of showing you, or the bowel and the rectovaginal septum, those people not uncommonly have features of adenomyosis. And it may be it's sort of it could be a separate disease, but it's obviously sort of related.
Mm-hmm. Let's go through these questions again.
But the point is to be really careful looking for adenomyosis, because that's going to dictate how you run things.
Mm-hmm. So there's a question here about management of period pain if the patient doesn't want to go on the pill. So what sort of things do you talk to women about in that circumstance? I guess in terms of not wanting, if they've got contraindications to estrogen, but also if they don't want to use hormones at all, which we definitely see women who don't want to use hormones. Yeah,
that's a huge problem, and there's lots and lots of people like that. So as far as I can see, they sort of fall into two broad categories. So one group of the people who think that taking any sort of hormone, any drug, any medication is foreign and not natural. And to that I respond that, look, natural and normal for human females for sort of tens, hundreds of thousands of years back in the day was to start having periods about 16, 18, and then to spend most of your reproductive years either pregnant or breastfeeding. So normal is actually not menstruating, but being anovulatory. So that if you mimic that state using the pill, that's actually more normal than being an incessant ovulator. So nuns, for example, and people who have incessant ovulation are more likely to have ovarian cysts, endometriosis, cancers and things. So that's the first aspect to it. And the second thing is to say, okay, look, a lot of people have an issue with mood. So it's reasonable to change different progestogens, but they can become sort of problematic. It may be that some of the more recent progestogens are less of an issue, and it's worth changing those around. But if they're if they can't handle any of those things, well, then I'd fall back on, okay, they're probably going to need surgery. And then I'd be looking at N-acetylcysteine, turmeric, physiotherapy, pain management, education, all those sort of things. And then pregnancy. It may be that it would be in their interest to bring their pregnancy planning forward.
Mm-hmm. Do we know how the NAC works, the N-acetylcysteine?
Don't think so, other than to say that's sort of anti-inflammatory, obviously, but does it decrease free radicals and all that stuff? Not sure, but a lot of people, I talk to, they're already on it.
Mm-hmm. And then have you found that there's a difference between combined oral contraceptives versus progesterone-only contraceptives in terms of helping with symptoms for these women?
I think it's a bit individual, and it sort of depends on the side effects, and it depends on their. A lot of them have, as I say, mood issues, and that becomes highly problematic.
Mm-hmm.
So it's very reasonable to start with a contraceptive pill, although clearly that's got or a combined pill that's got an estrogen, so maybe that's not such a great way to go. I've had some really great success with Visane over the years, and I've also it's been really good to add things together. So if something's not working and the side effects aren't too bad, then it may be reasonable to add in another agent, a different progestogen, and preferably a long-acting one,
mm-hmm.
like Marina or Implanon, or combining those two. So we work with a lot of people on that. So Ian Fraser sort of started doing that many years ago, and we're doing it with him, and he ran a trial, and it was very successful.
Okay. Oh, and there's a good question here actually about NSAIDs for period pain. Do they work well, and do you suggest them, and which ones do you suggest?
I don't. They work sort of moderately well. They're not for everybody. If you're getting away with utilising that and that's all you need, that's great. You need to be aware that they are mildly contraceptive, in that they can inhibit ovulation. So in the subgroup of people who are trying to get pregnant, they're probably not a great idea.
I didn't know that. There you go. So there's another one here about what is good management of irregular bleeding. So bleeding for 3 or 4 weeks of the month in a young patient with endometriosis who's had surgery and already has a Mirena and an Implanon and still bleeding. Is there anything else you'd add?
Yeah, I just keep adding stuff. I'd add Visane at that point. But I mean, that's it happens. But I wonder whether some of those people sort of tend to exaggerate. Let's put it that way.
Mm-hmm. So just going back to those pills again. So the progesterone-only pill, so a mini pill, that's enough progesterone for endometriosis management in some cases?
Yeah, absolutely.
And then have you, just because I've been thinking about it the last few days, Slinder, have you used Slinder in people, and has that been helpful?
Yep. And that appears to be better from a mood perspective.
I've had variable success with Slinder in terms of bleeding patterns for the patients I've used it in so far.
I have the same experience.
Yeah, so some people really love it, and other people stop taking it after 2 weeks because they hate it.
I haven't found the people who hate it yet, but maybe I just haven't used it enough. But yeah,
maybe my patients are picky. So there's a sort of question here about the risks of laparoscopy in patients, and I guess the risk, the question is sort of about a woman who unfortunately died during an endometriosis operation, and I guess the question is about weighing up the risks versus the benefits in these women, and how you manage to do that, I guess.
I try and individualize it for people so that, you know, if I don't think that you're going to get a significant benefit, I'm sort of pretty reluctant to want to operate on you. So particularly sort of younger people, I mean, as I say, if you're 16, 17, pretty unlikely that we're going to make a massive impact surgically because they're just not going to have a significant sort of endometriotic load, as it were. And then at other times, if people are contemplating getting pregnant, you know, and they haven't sort of started, it might be reasonable to give them, you know, 3 to 6 months to try and get pregnant spontaneously, because that might resolve the situation. You know, ideally you don't want to operate for all of the reasons that you know. Death from endometriosis surgery is pretty rare, but there is a problem in the sense that I think broadly, you know, a lot of people don't believe that sort of significant endometriosis exists. And I have seen a reasonable number of people who probably have operated outside their depth with, you know, significant problems as a consequence, with rectal perforations, you know, bladders, ureters. It's the same with all sort of surgery. It's just a sort of a, you know, the person who you're referring to, is that someone who's experienced? Are they going to have an issue? You know, what's their ego like? Are they capable of operating and saying, look, this is too difficult, you need to go somewhere else? Or look, you know, they'll just have a go at it. So I think it's a complex question. It's difficult to answer that. But in the main, sure, if you can avoid operating, by all means do so. But the other problem that also becomes, you know, it's a bit like that old Australian sort of cliche: if your only solution is a hammer, then every problem becomes the nail. And in the fertility world, that's really common. So there's bucket loads of people who've got obvious, demonstrable, big-time endometriosis, and they've had 4, 5, 6, 10 cycles of IVF. You know, that's clearly not helpful either. So if you're having IVF and you're not pregnant within 3 stimulated cycles, you've got to do something different, and you really need to exclude endometriosis.
And then what are the success rates for IVF after endometriosis surgery? Is it significantly better?
Yeah, so my preference would be to operate on people who've got really, really horrendous endometriosis, where people are told, look, this is horrible, you shouldn't have an operation, risks are too high. Those people do really well, both from a pain and a fertility problem perspective. The people who are more subtle, less of it, they get less of an issue. But hard to generalise. But in the main, it's a sort of stage-rated effect. So the more severe your endometriosis, the bigger the improvement. So I tell people it's a little bit like if you imagine, you know, at the age of, say, 30, your chance of getting pregnant per cycle is roughly equivalent to rolling a dice. If you've got per month, if you've got endometriosis, it's a bit like adding a few extra sides to the dice. The more, you know, the worse the endometriosis, the more sides you're adding, and as you remove it, you get back to more normal again.
There's a question about tranexamic acid for pain and bleeding, and if it's helpful in your experience.
Very helpful for bleeding. So we use it, you know, intraoperatively. You know, as you know, people use it for car crashes, you know, any sort of bleeding. So it's great, particularly for those people who've got bleeding issues and are trying to get pregnant. From a pain perspective, I don't think it has such a big impact.
And then another question here about women. The question is about women post-hysterectomy and using HRT for those women, and if estrogen-containing HRT will flare up endometriosis that's left behind.
Yeah. No, great question. So it can be quite difficult, and it sort of depends on the sort of particular circumstance. But if they've just had if they've had really big time endometriosis and you think there's some residual disease, or they haven't been operated, or they've had an endometrioma or whatever, then they should definitely have a progestogen as well, particularly for the first sort of couple of years postmenopausally. Otherwise, look, you know, an estrogen alone is probably reasonable. If you're in doubt, I'd probably add a progestogen in.
Mhm.
There's certainly case reports of recurrence malignancies and things in that subgroup of people.
So is it something that you need to take into consideration, that giving these women HRT at all might flare up their endometriosis, or not really?
I don't think it does really. I think that the systemic sort of dose is so low that I don't think it really flares. If it really does flare, and particularly if you've got some sort of imaging change, then they've got a cancer.
Mm-hmm. There's a question here about, I've read that endometriosis is more common in Ehlers-Danlos and hypermobility. Do you know if that's true?
I think
and if so, why?
I don't know why, but as I related to, there's some of those. I've certainly got several people with that combination of issues. No idea why.
The question actually went on a little bit and said something about maybe different collagen and more likely to seed to the pelvis potentially.
Yeah, possibly. What
else have we got? There's a question here about biomarkers. Can you comment on biomarkers?
There's a heap of them being looked at. The classic was CA-125, which is really not all that useful in the sense that it's very often elevated in people with endometriomas, but really bears no reflection in terms of cancer. And when patients, I don't use CA-125 other than if I'm worried about some unusual sort of mass. The reason is that, it's not going to help me in my decision making, and it's going to increase the anxiety of the patient, in particular because they're concerned they've got a cancer, and then you get pushed into doing things that you may not want to do. From an experimental point of view, there's research teams all over the globe looking at new biomarkers, but we're yet to see anything that's of use clinically at this point.
Mm-hmm.
But I think the future's sort of bright. I'm sure there will be something in the not too distant future.
Another question about adenomyosis. How do you manage it in general, including, premenopausal women, postmenopausal women, if it's causing bulky uterus and sort of problems to do with that? What's sort of your approach?
So again, it sort of really depends on the individual circumstances. So, if in young women, if you see someone who's 25, 27, 28, and they have an ultrasound that's suggestive of adenomyosis, I tell them that's what's happening. I suggest that we run things aggressively. So I often would use almost straight off the bat symbiotic, Mirena plus implant if they're not trying to get pregnant. I tell them that I'm concerned that this might create an issue such that their pain might be such that they want to do something sort of radical like hysterectomy before they've had children. So they should rethink their pregnancy sort of plans. And then, if we need to operate. It's not uncommon to concurrently have both endometriosis and adenomyosis. So that's the sort of the younger sort of age group. People who are trying to get pregnant, you might be forced into the situation where you might be pushed into doing IVF to decrease the time to get pregnant, appreciating that you might increase sort of the pain, but if it takes you sort of 6 to 9 months, as distinct from sort of 1 or 2 cycles of IVF. So IVF to a certain extent compresses time. So you've got several follicles equivalent to several months, and you squeeze time. So to decrease their exposure to pain, it might be reasonable for them to contemplate IVF as distinct from attempting a spontaneous pregnancy. And then in the sort of in the older people, in the 40s but still premenopausal, then I would throw everything at it in terms of progestogens, Mirena, and then if that doesn't work, hysterectomy. And then in the postmenopausal women, they shouldn't have adenomyosis and they shouldn't have pain.
And then everyone who has adenomyosis, will they also have endometriosis?
No.
So that's two. So you can have one without the other.
Yeah, and it might be that there's sort of two subgroups. So there's one group is associated with endometriosis, and there appears to be a second group who don't necessarily have endometriosis, and they tend to get it. I mean, classically, we used to sort of, we're taught that adenomyosis was a disease of people in their sort of, mid-40s, and it was a separate sort of condition. But there's probably another group who have concurrent endometriosis as well, who tend to be younger.
And then just on the sort of fertility stuff with endometriosis, I mean, I guess conventional sort of teaching for GPs is that, give women 12 months if they're less than 35 to fall pregnant, 6 months if they're over than 35. If you have a woman who has endometriosis, should we be referring those women earlier for a talk about fertility, at least, if they're not falling pregnant?
You could, but you can sort of probably do it yourself, in the sense that, as I say, the way I explain it to people is, look, it's a little, well, firstly, I say, look, I do a reasonable amount of IVF. IVF has been around for a long time, but in the scheme of things, it's not really that long. And there's some suggestions that the offspring of that process possibly has some vascular issues or potentially some aging issues. And clearly we don't know anything about the next generation at this point. But it strikes me that we're somewhat naive to think that we can advertise this technology on the side of buses and we can do it sort of, without any issues, and that it's that it has no consequences. And I think that's probably misguided thinking. And I wonder whether we might look back in future and think that, okay, there was some of these people should have had this procedure, but maybe not quite as many as have. So at a high end point, I sort of try and dissuade people from IVF if I can. If there's anything we can do to achieve a spontaneous pregnancy, I think we're going to have a better quality offspring. And then, from a where am I going with this? I sort of lost my train of thought. But what did you allude to? As to
if we should refer women with endometriosis earlier.
Yeah. So, I put it to patients, okay, as I say, it's a little bit like rolling a dice and waiting for, your six. If you're, say under 35, then it's probably that sort of number. But if their pain's pretty significant as well, then they're probably better off, to look at having a laparoscopy, because they may be having some significant issues with, pain with intercourse. So you can sort of resolve both those issues. Obviously, if they've got, early on, you'd want to do a sperm count, because if they've got endometriosis and a sperm issue, you might be better off to go straight to IVF. Just depends. You've got to put all that into the mix.
Mm-hmm. And then women with endometriosis, if they do go on to have IVF, do they don't have any extra sort of risks compared to women without endometriosis? There's no, they're not going to get worse, or?
Well, look, there's a theoretical potential, and it does happen that some of those people will get an exacerbation in their symptoms, particularly if they've got a lot of disease still there. If they've had sort of big time surgery, so some people, we remove, bits of bowel, bits of top of the vagina or whatever. So they can have, it can be a lot more painful, during the stim phase. And there's perhaps a slightly increased or a slightly higher risk of, infections and things, although that rate still does remain, it still is pretty low.
And you said before their outcomes are pretty similar in terms of IVF outcomes?
So I think the IVF outcomes are probably not quite as good as people who don't have endometriosis. And specifically when they're running cycles, it's my impression, so we're pretty sure that we get better quality offspring in the frozen cycles as distinct from the fresh cycles. And that may be because the eutopic endometrium of people with endometriosis is abnormal, And so if you stimulate that endometrium in the sort of the fresh cycle, you make that abnormality potentially worse. So you're putting that embryo back into a more disordered endometrium. If, however, you wait and put it into an unstimulated endometrium, then you haven't exacerbated that underlying abnormality quite as much, in which case we appear to get more pregnancies. Mitigating problem with that is that more recently there appears to be some evidence to suggest that if you've started life as a frozen embryo, you might have a higher rate of childhood cancers than fresh transfers. So there's a bit hard to know about all that, but I'm of the impression that we get better success rates with the frozen cycles than the fresh.
We're almost at the end of our time, but there's just a few more questions I might put to you. There's a couple of questions actually along sort of the same sort of train of thought about clues in history for endometriosis in women with painful periods, and whether, you know, the length of the dysmenorrhea makes a difference, if you're more likely to think it's endometriosis if they've got dysmenorrhea for, you know, the whole period as opposed to one day. Is there anything that we should be specifically thinking about asking women?
I think, so the pain is, look, everybody tends to focus on the pain, but I think the other things that are perhaps more material is, as I say, premenstrual spotting, weird, heavy sort of bleeding, irregular things, and then things of a more systemic nature. So once they start getting bowel issues, backache, leg ache even, immune problems, then, you know, irritable bowel type sort of syndromes, then I think you're more likely to be looking at that sort of group. And obviously, if they've got a family history, that adds to it. You know, if Aunt Maud's had problems or whatever, then, you know, you'd be thinking it's more likely.
Along that sort of same line about irritable bowel syndrome, I definitely find in my patients with irritable bowel syndrome that if they're stressed, their symptoms get worse. Does that seem to happen with endometriosis?
Yep, for sure. I mean, I think stress just creates so many more issues. It exacerbates things. And I think what tends to happen with endometriosis, and possibly any sort of chronic issue, is that if you've got a steadily, slowly deteriorating sort of deal like endometriosis tends to be, you will have the cycles will be sort of different. So some months things will be okay, other months it'll be worse, and it'll sort of come and go. But the general trend will be slowly deterioration, slowly increasing in pain. At the same time, you know, you'll have a pain threshold, which will depend on a whole host of things: how much you've slept, whether you've got a relationship problems or a money problem or work or stress or whatever it is. And what I see is that when people sort of burst through that threshold, then the wheels fall off and everything seems to deteriorate much faster. In reality, it's probably just a small little, you know, worsening, but their perception is that it's much worse.
And then there's actually quite a good question here about how do we find gynecologists who are experts in endometriosis, I guess. Is there somewhere we can go? Is there a society or something?
Not that I know of. At the moment, you know, it's within our college, I think the broad sort of belief is that it's not such a big deal. There's a handful of cases of a big time problem, but the vast majority of people, and it's not such a big issue, and that, you know, most people can do it. We don't have any, you know, way of identifying that. I guess if you're concerned that someone does have something substantial, then you'd be better off to see somebody who does more surgery than doesn't do much surgery at all. And within our college, there's a lot of people who, so it's sort of notable to me that in, you know, in central Sydney, if you look at all the surgical disciplines, orthopedics, ophthalmic surgery, you know, abdominal work, people basically tend to specialise. You know, that's just the way it works. O&G is notable in that the broad majority of people tend to be generalists, and I think that's a problem with the explosion of knowledge and the explosion of things that are happening and movement into things like robotic surgery, for example. You just can't do it half time. You've got to be, you know, you need to be doing it on a regular basis, and I think that's the way you would differentiate. And I see that's the way it's going to sort of pan out, I think.
Mm-hmm. And then I was going to ask how you explain endometriosis to patients, because I find that women come and they've read a lot about endometriosis on the internet. And so sometimes I struggle just to sort of make it not so simple that it's sort of patronizing, but enough that it's sort of giving them correct information about what it is without being completely over the top, I guess.
Yeah. So what I do is I try and spend a lot of the conversation talking, basically saying that the narrative, the story, you know, the Google sort of stuff that they've all read is only partly right, and therefore it's wrong. And I tell them the definition, look, you know, okay, you can understand that little bit, but unless you get your head around the fact that there's all these other aspects happening, then they don't get it. They don't understand why, you know, why don't you just chop it out and away we go? So I show them all that sort of Lancet slide and say, look, what we're dealing with is, you know, the way you should be thinking about this is that you've got a condition that we don't understand. We don't know what causes it. But basically it's a chronic systemic inflammatory problem. And there's all these issues with, you know, the fluid within your abdominal cavity, your pelvic floor muscles going to spasm, referred pain to different sort of parts of you, and then these, you know, this unusual tissue within the pelvis. So, in other words, surgery alone is not the answer. So I try and dissuade them of the notion that it's simply just these aberrant cells. And hence, at the start of this sort of, you know, lecture, my initial, I think I'll bring it back up, but hit the wrong button. But, you know, I wondered whether really we should sort of change the diagnosis. Or should we widen the diagnosis, I guess I should say. So I think this sort of starting point, you know, should we expand the definition? That's what I try and illustrate to people. Because I think once they start to get the sense of what we're talking about, they can start to take ownership of part of their own problems. And that, you know, it's a joint sort of journey for a lot of these people. For some people, this is a really difficult thing. I mean, as you know, it takes over their life.
Mm. I think that's probably all the questions that we've got time for. Oh, there's just one more about, you were talking about turmeric for anti-inflammatory, is that right?
Yeah.
And do you know if low dose naltrexone helps?
Awesome question. I suspect it might, but I haven't personally used it. But I think if someone's thinking about it, I think that it would be interesting. And if whoever's doing that, let me know, because I think it's. I mean, I'm sort of open. As I say, since we don't know what this is, I don't sort of feel as though I have the all the answers at all to this. So if there's, I think there's, you know, there's lots of different ways we can approach it, and I think these sort of approaches are very useful.
Mm-hmm. And just a dose of turmeric? Do you know what dose you're using?
500 milligrams. But having said that, you will be aware that there's issues with liver toxicity in some of these people, and some of them are taking different other agents. So I actually suggest that if they're going to do some of these things, they should go and have a chat to a naturopath or a dietitian and just see what else they're doing. Because often people are taking sort of multiple preparations and you really don't know what's happening.
Mm-hmm. Well, I think on behalf of everyone, I'd like to say a really really big thank you. It was very informative, really helpful for GPs.